Good morning. This is Dr. McDaniel. It's Tuesday, April 23rd, and I'm still here in Florida, hopefully finishing. We'll see. I'm trying to keep all of the broadcast to 10 minutes. So yesterday I spoke on fibroids. I discussed that fibroids are balls of uterine muscle, and we call them fibroids. We call them also myomas because they're tumors of the muscular layer of the uterus. You can also get fibroids of the cervix because the cervix is a muscular entity, and you can have fibroids in each of the three layers of the uterus. So you can have subserosal fibroids, which are fibroids pushing out from under the skin of the uterus, intramural, which are fibroids bulking up the walls or the meat of the uterus, and submucosal, which are balls of uterine muscle or fibroids pushing into the cavity of the uterus. And that you can have metastatic fibroids, which fall off the uterus, basically grow in differing areas in the neighborhood, or you can have aborting myomas, which are fibroids that fall out of the uterus through the cervix as if you're giving birth to them. Fibroids are benign 99% of the time. Less than 1% of fibroids are cancerous. We call those sarcomas. And sarcomas, really, we don't have any way of detecting if someone has a sarcoma. The biggest clue is if they have a fibroid that's growing rapidly. So say it's doubling or tripling in size in a very short amount of time. And a short amount of time would be a couple of months or so. The bulk of fibroids obviously are benign, so it's not necessary or it's not important to treat them unless they're causing someone grief. And by grief, I mean a lot of symptoms that makes it difficult to continue with activities of daily living. We can divide fibroids into the symptoms that they produce. The major symptom that fibroids will often produce is heavy menstrual cycles. And that's because fibroids that are submucosal, they pooch into the uterine cavity, they can cobblestone or dimple the cavity quite a bit. And if they cobblestone or lump up the uterine cavity, they increase the surface area. When you increase the surface area, you increase the amount of blood that builds up or the flow. So instead of having 4 to 5 day cycles, which is the average, one would have 2 to 3 week menstrual cycles with huge clots of blood, fist-sized clots of blood even. So in that scenario, I discussed that there's an evaluation process. We don't just assume it's from the fibroids or from the fibroids uniquely. We have an evaluation process. That process involves checking for infection as a source of the abnormal bleeding, checking to see if it's a medical condition, so a hormonal problem or a medical issue, checking to see if it's from other physical sources such as polyps, masses, growth, abnormal tissue distribution or buildup, hyperplasia, or even endometrial precancer, cancerous changes remote from the fibroids. And then an ultrasound or a sonogram to confirm all of that. Rarely do we need to do an MRI, but an MRI is sometimes done to differentiate if it really does look like a uterine fibroid or not in the blood supply. And then sometimes additional sonographic testing called a saline infusion sonogram to delineate how much of the fibroid may or may not be potentially pushing into the uterine cavity and if there are contributing factors. And a biopsy to confirm that it's really all due to fibroid, the abnormal or dysfunctional bleeding versus tissue changes is what the purpose of the endometrial biopsy or the uterine sampling of the lining of the uterus. Once all of that is completed and it has been determined that it's uniquely or solely or specifically only due to the presence of the fibroids distorting the uterine cavity, then the treatment for abnormal bleeding would simply be birth control pills, because birth control pills are hormones that manipulate the uterine lining or where the blood builds up in the uterus. So it dictates how much blood builds up and it dictates how much blood is cleaned out. Birth control pills, we have a gazillion and one birth control pills. 98% of the birth control pills are considered low dose because they're all 35 mics of estrogen or less. We used to have 60 mic hormone level birth control pills. You can't get those anymore. That's a high dose pill. And a moderately high dose pill is the 50 mic pill. Pretty much only have one company that produces the 50 mic pill, and it's very difficult to get it, but we predominantly use that for abnormal bleeding issues where people cannot tolerate the lower doses. They need that higher dose because it's more stimulating, and they're able to stabilize the lining inside the uterus better with the higher dose. For these purposes, for abnormal bleeding due to uterine fibroids, the low dose pills are all fine. They start at 35 mics. They go from 35 to 30 to 25 to 20 to even 10. Most women will need either a 20 to 25 mic pill. Usually I do a 25 mic triphasic pill because it manipulates the cycle and stabilizes it faster than the lower dose pills, and every 6 months I'll work down to either the 20 or ideally the 10 mic pill because that would shorten and lighten the cycles the most. So the birth control pills manipulate how much blood builds up and they manipulate how much blood clears out. You can do them as a monthly cycle pill or a pill where you only get the cycle every 3 months. And if someone has, say, 12 to 14 day cycles completely solely due to the fibroids, that 10 mic pill will predominantly decrease their flow to, I would usually almost about half of where they started. So it would stop the flow to around 4 to 5 day cycles if they started out with a 12 to 14 day cycle. 4 to 5 day cycles, maybe 6 to 7, but very, very, very light and petering out at the end. So a huge or a vast improvement. That's the major part for reviewing the fibroids and the management, the evaluation and the management if someone has heavy flow. The other possibility is not that they have a heavy flow, because if they don't have those submucosal fibroids that are pushing into the cavity and increasing the surface area, then they'll have intramural or the subserosal ones that are basically bulking up the uterus and giving them a big, huge uterus with a small cavity. If the cavity remains small, they're not going to have heavy, long cycles. They're going to maintain their normal cycles. But the size of the uterus can get huge, where someone can look like they have a 9 or a 10-month pregnancy. So tomorrow I'll do a quick review and I'll go over the management, the evaluation, the management for a huge uterus where you have normal menstrual cycles. I hope that was helpful. This is Dr. McDaniel. It's Tuesday, April 23rd, and that's part 2 on uterine fibroid evaluation, management, and treatment. Thank you for watching. Have a glorious day.